Great.
Okay, so good afternoon and welcome everyone. I'm Candy Welch and I'm pleased to be here hosting and moderating this webinar for Brain Support Network, a nonprofit focused on education for MSA and Lewy body dementia and brain donation for all neurological disorders. I'm currently on the BSN board and serve as a leader of our local MSA caregiver support group in the Bay Area. I did care for my husband, Bob, who passed away in 2008. His MSA diagnosis was confirmed following his brain donation. Stanford is very pleased to offer our third webinar in our occasional series on Parkinson's and atypical Parkinsonism disorders. We're recording today's event and loading it to YouTube, so we hope you will pass it along to others who may be interested to hear what we have to say today. Watch your email after the event for the link. Brain Support Network will also be posting a summary on our website. Today's webinar focuses on multiple system atrophy and cognition. After our speaker concludes, we will hold a question and answer session. Throughout the presentation, we hope that you will submit your questions using the Q&A button that you will see at the top of the screen. In addition, we have received many questions in advance of today's webinar. We'll attempt to address as many of these questions as possible during the time allowed. We also ask that you complete our survey after the webinar concludes. We look forward to receiving your feedback. The link will be on our slides and in the Q&A box that you'll see at the top of your screen. We thank you in advance for helping us improve. Our guest speaker today is Kathleen Poston. Dr. Poston is a movement disorder specialist at Stanford University. Dr. Poston's research focuses on the development of neuroimaging biomarkers to improve diagnostic accuracy and monitor the efficacy of investigational treatments for Parkinson's disease and other movement disorders. Her current studies focus on cognitive and memory problems in people with Parkinson's disease. Now I'm very pleased to turn things over to our guest speaker. Welcome, Dr. Poston.
Thank you so much, Candy. I really appreciate the opportunity to be here. So just seeing if I can advance the slides here. It doesn't appear that I can. There we go. Okay. So thank you so much. So yes, we'll be talking about cognition in multiple system atrophy. I'm going to talk for about 30 minutes here because I want to leave lots of time at the end for questions and answers. So hopefully some of those questions that came in ahead of time, I'll get a chance to address. Otherwise, please do send in your questions as we go, and we'll try to make sure we touch on as many as possible. As was mentioned, there's a diverse audience today, which is very exciting. So I'll try to make sure to talk about things with hopefully as non-medical language as possible that anybody can follow along with what we're talking about. So first of all, let me just give make sure that we're all on the same page as far as the diagnosis of this disorder, multiple system atrophy. So there have been a couple revisions of the consensus statement regarding exactly how the diagnosis is made, and the most recent one being a little while ago. But in general, the idea is that every person with multiple system atrophy has a component of what's referred to as autonomic dysfunction that is required for the diagnosis of MSA. And autonomic dysfunction can have a couple of different variants. The most common is blood pressure fluctuations, typically seen as blood pressure drops, either with standing or with sitting, but also can be just dysregulation of blood pressure where it goes really high and then really low. So it doesn't always have to be low. Sometimes it can be fluctuating. But there can be other autonomic symptoms such as urinary symptoms, urinary frequency, urinary incontinence, constipation, sweating, sexual dysfunction, and other autonomic symptoms. So some flavor of autonomic dysfunction is required. In addition to that, patients can have some sort of a motor symptom, and that motor symptom can either take the form of Parkinsonism, which is described as slowness, stiffness, and muscle rigidity, or it can be in the form of ataxia, which is a poor coordination. And so these are slightly different forms of motor symptoms. And we typically refer to the subtype of MSA as MSAP if it's more of that slowness, stiffness, and muscle rigidity, and MSAC if it's more of the discoordination or ataxia, C standing for cerebellar subtype. But we recognize that there are a lot of patients who have a mixture of these two. So these symptoms are really the ones that have been the typical focus of MSA, both as far as diagnostic as well as for research for many, many years. However, in addition to, and this is just sort of going through those again, the autonomic symptoms being the blood pressure, other types of autonomic symptoms, the Parkinsonism, and the cerebellar symptoms, again, thinking of coordination. So these are in the realms of autonomic and then motor symptoms. But it turns out there are a lot of other non-motor symptoms that can be experienced by people with MSA that don't fall under these big categories. And the diagnostic criteria for MSA, which again, 2008, so it's a little bit old. It's actually in the process of being considered for revision. This original diagnostic criteria traditionally said that if you had dementia, which I'll give a formal definition for later, but right now just broadly thinking really, really bad cognition and memory, that if a person had dementia, this was considered to be a red flag, meaning that this was a way of the doctor saying, oh gosh, the diagnosis is not MSA, it's something else. However, more recently, it's really been recognized that both memory and cognitive problems can, in fact, happen in patients with MSA. And so this is why we're having this particular conversation, is because traditionally, cognition has not been really thought of much in terms of MSA, and even has been a signal that the diagnosis is not MSA. But recent research has really challenged this idea, and I think informed us that we need to think much more broadly about patients who have MSA. So we divide the different types of symptoms into classic motor symptoms, so classic things that happen with the motor, so that ataxia or coordination, the Parkinsonism with slowness, which we call bradykinesia, tremor, and muscle rigidity. And then there are some mixed motor, non-motor, so some speech problems, which again, sorry that we have these fancy words for things that should just be easy to describe, but hypophonia is a soft voice, dysarthria is poor coordination with speaking that sounds slurred, gait and balance problems. These have both a motor component and non-motor component. And then there are these very traditional, what we call non-motor symptoms, which again can include the autonomic dysfunction on the bottom there, the constipation, orthostatic hypotension, urinary urgency, and urinary incontinence, but can also include sleep problems, can include mood problems like depression, apathy, anxiety, fatigue, but can also include these memory problems, mild memory impairment, very rarely, but sometimes even dementia, and sometimes what we refer to as psychosis, which is really hallucinations and delusions. And I will circle back and give a more in-depth description of what I mean by that toward the end of the talk. So I'm going to break down the types of memory or cognitive impairments that people experience into three big buckets. The types of cognitive changes that happen suddenly, the types of cognitive impairment that happen intermittently. So a patient goes from being pretty good cognitively to having a lot of problems to being good again. And then those that slowly progress over time, over months or 6 to 9 months. Because these are typically have different causes and need to be addressed a little bit differently. So let's start off with talking about, sorry, my screen is not advancing here. Oh, sorry, I went too fast then. Okay, sudden change. So sudden change in cognition. So the most common reason for a sudden change or a sudden onset in any kind of specific symptom, but cognition being one of the big ones, is a general medical illness or a medication. And what I mean by that is that if someone's pretty good cognitively one day and they wake up the next day and they are confused, they're seeing things that aren't really there, they're harder to wake up, usually this is something general medically. That's not the way the disease course of MSA typically progresses. And what I think of when I get a phone call like this is I think of infection as like number 1, 2, and 3 on the list. Typically something like a urinary tract infection, but even the cold or the flu can do this kind of thing. And it turns out that people who are older or who have neurological diseases don't always mount a fever when they have an infection, and don't always have classic symptoms of a urinary tract infection like burning or difficulty urinating, because they experience that all the time. And so infection's the number one thing. But other medications can also cause this, particularly pain medications. Interestingly, any significant stress like severe constipation, a terrible night's sleep, recent travel, being in a new physical environment can also cause a change in cognition. It's not uncommon for me to get a call that a patient and family went on a vacation and they're in, their in-laws' house, and they wake up the next morning very confused. That often from the travel, the lack of sleep, new environment, all that can cause it. And then of course, being physically in a hospital for some other hospitalization, because this really incorporates everything I've said on this list: the emotional stress, physical stress, often you're on new medications, frequently having an infection. So all those things can cause a change in cognition. How do we treat it? You deal with the underlying cause. So whatever that, you do investigative work to figure out, is this a urinary tract infection? Is this a recent change in medication? And you deal with it. In addition, you also stop other medications that could be contributing to the memory problems. And I listed a couple of them here that can sometimes make memory problems worse, particularly in that acute setting. Now, most of these medications are typical medications given to people with Parkinson's disease, but I have seen all of these given at some point in time to people with MSA as well. And this list of medications can sometimes, particularly if someone's really sick or has an infection, can actually make cognition worse. So we sometimes think about reducing or stopping these medications, at least in the short term. So what about this intermittent cognitive impairment? So we call this fluctuations, and it can be associated with level of alertness. So someone's paying attention, they're able to follow what's going on. 2 hours later, they're having trouble focusing on what you're saying. They might not make very good eye contact, might be sort of answering questions randomly, and then maybe a couple hours later, they're doing pretty good. So when we think about these fluctuations, I think about whether or not there's something that's triggering the fluctuations. And I'm going to give you 3 situations when that can happen. The first one is when the lack of a medication is causing a symptom. So a lot of patients with MSA can be taking this medication, Sinemet. This is just one example. Sinemet is carbidopa, levodopa, again, traditionally given to people with Parkinson's disease, but oftentimes given to people with other Parkinsonian disorders like MSA. And let's say someone's taking a medication at 7 o'clock in the morning, at 10 a.m., and at 1 p.m. And a symptom starts about an hour before they take their next dose of medication and then goes away 30 minutes after they take that medication. Well, this is an example of a symptom, maybe difficulty focusing or concentrating or decreased alertness, that actually improves with taking the medication dopamine. And the only way you can figure that out is to do a diary like this and tag the time the symptom starts with the time the medication starts. Scenario number 2, same medication, same 3 times a day, 7 a.m., 10 a.m., 1 p.m. But with this one, the symptom, maybe confusion or difficulty focusing, happens for the hour after they take the medication. Well, this is then an example of a non-motor symptom like cognition worsening with taking a medication. You take the medication, 20 to 30 minutes later, after the medication dissolves and gets into the bloodstream, the patient experiences a symptom such as confusion. And then after about an hour later, that symptom goes away. Again, the timing of the medication with the onset and end of the symptom is kind of the only way to figure that out. Scenario number 3 is when the medication and the symptom have nothing to do with each other at all. So the patient still takes the medication at 7 a.m., 10 a.m., and 1 p.m., but in the morning, the symptom starts after the medication. In the afternoon, the symptom starts before you take the medication. So it's really hard. What's going on here? What's triggering this? Well, what else is happening at 7:30 in the morning and at 12 in the afternoon? That's when someone eats. So this is a symptom that has nothing at all to do with the medication, and actually is a symptom that happens after meals. And a classic example of this is blood pressure lowering after meals. After we eat a meal, all of your blood rushes to your GI tract to try to digest that meal. And by going to the GI tract, it goes away from the brain. And it is not uncommon for patients with MSA to actually have fluctuations in cognition and memory that are associated with fluctuations in blood pressure. When the blood pressure is really low, not as much blood is going to the brain, there might be parts of the brain that actually aren't functioning properly, particularly those with a level of alertness or mental functioning. So if someone's having fluctuations in their cognitive status throughout the day, particularly if it's timed by certain events like eating, when we know blood pressure is low, this actually might be a sign that its cognition is not the primary problem. Rather, something like blood pressure fluctuations are the primary problem. One way potentially to test this is when somebody is having the symptom to check their blood pressure and see if it's substantially lower than when they are thinking normally and thinking clearly and interacting with people normally. It's sort of one way to tease that out. So this is an example. These are 3 examples of fluctuating cognition that sometimes is related to medication, sometimes not, sometimes related to something else like eating. So now let's talk about the slowly progressive changes. So these are the ones that we actually know more about because of recent research. And this slowly progressive change in cognition is more likely to be actually part of the underlying disease process. So I'm going to break down to the different types of cognitive domains. What I mean by that is that cognition, the reason I'm using the word cognition and not memory is because memory is just one piece of cognition. There are many different pieces. And we artificially break cognition down into these 5 or 6 different domains. And the reason for that is that these different domains in some part represent different parts of the brain, although there's a lot of overlap, as I'll explain in a minute. But different diseases tend to affect different domains more strongly. So for instance, Alzheimer's disease oftentimes affects memory and language more strongly, whereas MSA does not tend to affect language or memory quite as much. So it's a domain specificity in different diseases. So let me just give a quick example of each of these. So memory. Someone asks you, or on your way out the door, your spouse asks, can you pick some milk up while you're at the store? And you get to the store and you walk to the dairy aisle and you have no idea what it is that you're supposed to pick up, right? This is an example of this short-term memory, is that someone told you something and 20 minutes later you cannot remember what it is. Well, there are 3 different parts to memory. There's encoding it. So did you pay enough attention when you heard you're supposed to pick up milk? Were you able to maintain it while you were driving to the grocery store and listening to the news? And when you actually got to the grocery store, could you remember the right thing at the right time, right? Because if you're in the potato chip aisle and that's when you remember that you have to get milk, that's not helpful. There's not milk on that aisle. You have to remember it when you're in the dairy section. And so is retrieval not just do you remember it, but do you remember at the right time? Processing speed is oftentimes referred to as the time it takes to absorb new information and come up with a response. The reason why this one is sometimes considered one of the domains, sometimes not, but this is one that is oftentimes affected in MSA, and I'll show you some data to support that in just a second. Attention and working memory is your ability to focus on something very quickly, do something with it, and then forget it down. Forget about it after you use it. So an example is someone tells you their 10-digit phone number. You have to keep it in your mind while you get your phone out. You enter your 7-digit code. You open up their, your address book, and then you type it in. And then once you type it in, it's gone. You're never going to remember that phone number again because now it's a contact on your smartphone, right? But you had to keep it in your mind for that 2 minutes that you had to open up your phone and get it to the right place. So that's attention and working memory. Very short periods of memory where you're highly focused on one thing and then you just forget about it. Executive function uses attention and working memory, but this is more complex processes. This is what we call cognitive processes that dictate flexible and dynamic adjustment of performance in response to a changing environment. So examples are things like planning, complex novel solving, shifting. Can you sit there working on an email and then get a phone call, talk for 5 minutes, and then go back and be, boom, right back onto whatever email you were doing? Can you not be too susceptible to distractions? Fluent word generation comes under this. Learning rules of a new task without a lot of direction. Can you figure out how to do the programming for your new DVR after you switch from Verizon to Comcast, and now you got to figure out how to record all your shows with a new system without someone telling you how to do it. That's all executive functioning. Visual spatial, this is an example of can you match the picture there to the one on the bottom, which is a similar type of shape, and the match is with number 2. This one's harder to conceptualize how it interferes with day-to-day life, but one way to think about it is when people are parking, your ability to determine where the curb is in relation to where the car is. So clipping corners or having a hard time sort of getting spacing right. Another example is having problems with direction somewhere that's not familiar, getting turned around really easily. And finally, language can be something simple like the names of objects or people, but it can also be more severe, like not being able to remember something that you use regularly, like a lawnmower that has a more complete, it's not something you use in regular conversation, but maybe if you used to, as a kid, you got all of your weekend change by mowing lawns, and now you can't remember what the name of that little thing is. It can be a evidence of a language problem. Again, language problems not as common in MSA. So I just want to define dementia for a moment, because dementia is just a symptom. A lot of people equate dementia to Alzheimer's disease, and while Alzheimer's disease is the #1 cause of dementia, it is not the only dementia. Dementia is just a symptom, and is defined as when a person can no longer do a fundamental activity of daily living because of the cognitive impairment. Now, this can be tricky to figure out in MSA, because maybe someone's not driving because of their Parkinsonism, or they are ataxia, or maybe they're not cooking anymore because they're having a hard time manipulating, the knives, not because they can't follow a recipe. But if it's because they can't follow a recipe, then it's considered dementia. If it's because of the motor symptoms, then it's not considered dementia. So it can be really tricky to figure this out. Again, examples are things like getting lost when driving, not being able to shop for groceries because of the cognitive symptoms, not being able to pay bills correctly, again, because of the cognitive symptoms. And so it's when someone can't do something simply because of the cognition. So let's talk a little bit about some of this recent data that has suggested that cognitive problems are more common in MSA than previously thought. So this was a study that was published in 2014, a multi-center study, and they looked across all scientific publications in the last, I think, 10 years before this that had described any kind of cognitive problems in people with MSA. On the far left of your screen, the top is people with a combination of MSA-P and MSA-C. The middle was just studies that described MSA-P. And then at the bottom were studies that just described people with MSA-C. Across all of these, the most commonly impaired domain of all of them that I just mentioned was executive function. That was the most commonly seen across all these studies. You can see the references. There actually were quite a few papers. There are almost 30 papers that had described something of cognition in people with Parkinson's. In the middle, sometimes impaired, the other ones that were more commonly were things like that attention and working memory, some visual spatial, but you'll notice language really isn't on that list. It's not that commonly affected in MSA. And then some memory, some recognition and spontaneous recall, but again, not nearly as common. So again, the executive function, the most common, attention and working memory, and a little bit of visual spatial function as well. What they also found, and this is a different study, this is the same study, so that they then looked at people who had had autopsy-proven confirmation of a diagnosis of MSA. And they found that in that group, going back into their medical records, again, this is just patients with autopsy-confirmed MSA, 22% of them had had some description either on a cognitive test or had had a cognitive complaint of some mild cognitive impairments. 2% had had more moderate, and 0.5% had had severe, meeting the diagnosis of dementia. Interestingly, they found that 50% of the patients who had lived for more than 8 years after the diagnosis of MSA had cognitive impairment. So it seemed like this is not something that happens to most people early on. Really, in half the patients, it was after they had a diagnosis, not symptoms, a diagnosis for at least 8 years. So maybe this is something that tends to happen later. They did find that 14% of patients had a diagnosis of dementia in the last year before they died. And then again, there was one study that suggested that 9% of patients had visual hallucinations, but that was only one study. And you have to be very careful about percentages when it only comes from one study, because it could be very skewed. Maybe that particular clinic had a physician who was a specialist in cognitive impairment or hallucinations in MSA, so they saw a higher percentage. So it's hard to know how to interpret 9% in that context. But nonetheless, there's some patients that it was documented. Okay, so now talking about again, a different study. So this one was more recently published in 2017. This is a study that looked, basically they took, again, patients with autopsy-proven MSA, and they cut their patients into two different groups. Patients who had MSA-CI, that means cognitive impairment, and MSA-NC, that means cognitively normal. So again, these patients had autopsy proven, and about 1/3 had cognitive impairment, and 2/3 were cognitively normal. And they looked across the different groups, and again, you can see that the disease duration across these two groups was around 7 years. And let's see, the one thing to point out is where it said having a clinical diagnosis of MSA, it turns out the patients who had cognitive impairment, only 70% of them correctly had the diagnosis of MSA during their life. So if they had cognitive impairment, they were more likely to be incorrectly diagnosed as something else. Probably, again, because the consensus criteria from 2008 suggests that dementia isn't part of this, but it turns out it potentially is, and so those patients were more likely to be incorrectly diagnosed. Now, this is a very busy slide here, very busy slide, but I wanted to include it because there are some people who had asked ahead of time whether or not there could be a different diagnosis in addition to MSA that is contributing to the cognitive impairment. So this is the 33 patients who had cognitive impairment, again, with a pathologic diagnosis confirming MSA. And in the top group, numbers 1 through 9, these people had formal neuropsychological testing. In the next group, 10 through 16, these people had both neuropsychological testing as well as some subjective measures. The next two groups, 17 through 33, they just had subjective indicators, meaning the patient would complain of something, but they didn't do a formalized test. Again, you can see across the top, PS is processing speed. So again, how quickly they could cognitively process things. And ATN/EF, that's attention and executive function. The pluses mean those patients either had a test that showed they had that problem or they complained of it. Those were most common across the board. Very few people had language problems. Very few actually in this cohort had visual spatial problems. But if you go to the far right, you'll see a bunch of abbreviations. Those are the patients who, in addition to MSA, had a second diagnosis on pathology that might have contributed to their memory problems. AD is Alzheimer's disease. So there are, AD is Alzheimer's disease. And so in those patients, there are a couple, not that many, but a couple who had memory problems and also had Alzheimer's disease at the time of death. CV, that stands for cerebrovascular pathology. So basically enough small strokes that there might have been a vascular component that was contributing to the dementia. So it can happen, but as you can look at the list of 33, it's not that common. Okay, so now let's talk about this issue of psychosis. So it's a terrible word. I apologize on behalf of the medical community for using the word psychosis. I'm not the person who coined this as being what it's called. But basically what that means is a continuum from what we call illusions, which are misrepresentations of real stimuli. They can be unformed, such as a sense of presence near you, or seeing a purse on a chair and misrepresenting it as a cat, thinking a cat is sitting there, or seeing a jacket on the back of a chair and thinking a person is sitting there, or a shadow in the window and thinking that's a person. But then you look at it more closely. You say, oh, that's just a shadow. I don't know what I was thinking. We can all do that. And poor lighting, if we're tired, this kind of illusions, these can happen easily. But they're more common in people with neurological diseases. Hallucinations then are a spontaneous, fully formed vision. So seeing a cat sitting there and you're staring right at it, but there's no cat, or seeing a person in the room who isn't there. These are most commonly visual, but occasionally can take other forms. For the most part, patients have insight that they know that that is not a cat sitting there, or that that is not a little girl standing in the corner. They know that there isn't something there. They have insight that the hallucination isn't real. But it can happen where they don't have insight. Absolutely. And then delusions fall into where we think of false thinking, which can be paranoia. So there are people outside the window and they're trying to break into the house, and an entire story can sort of evolve around that. That is when we start thinking when the hallucinations actually turn into psychosis. Now, in general, we tend to put a line between these two, because anything above this line can be bothersome, but oftentimes the patient is aware of what's happening and is not that bothered by it. Obviously, if you're seeing things and you can't tell whether they are real or not, this can be really, really disturbing to patients. And obviously, delusions can be very disturbing. And so we think of anything above the line as a mild psychosis or a mild hallucination, and anything below the line as a more severe hallucination that probably needs to be medically addressed. The problem is that some of the medications we use to help with the motor symptoms, like the ones I gave at the beginning, the Cinemet medication, the dopamine agonists, those can help with movement, but they can all make the hallucinations worse. And so if someone's having hallucinations, we oftentimes have to have the conversation with the patient that maybe you need to decrease your dopamine medications, and that might mean you don't move as well, you can't walk quite as well, but you're going to realize that that cat isn't really sitting there, or not be bothered by the people standing outside the window, because you'll recognize that it's just shadows and it's not actually people. So it's a balance, and it's a very, very difficult decision to make. And this involves the patient, the family, and the physician who's taking best care of the patient. So again, sudden onset of worsening hallucinations, oftentimes due to an underlying medical illness, just like the sudden onset of worsening cognition. So the very first thing I do if someone calls my nurse and says my spouse is suddenly seeing things that aren't there, we send them to the urgent care to get to make sure they don't have a urinary tract infection, because that's something that can be treated immediately. And if it's not treated, it can be much worse. So think of the same list. Again, same issue of treating a sudden change in hallucinations. Deal with the underlying cause, reduce the worsening medications to try to make it go away. Again, a sudden change. This is how we deal with it. Okay, so I'm going to wrap up here by addressing some differences between multiple system atrophy, Parkinson's disease, and Lewy body dementia. So as I mentioned, the motor symptoms of ataxia or bradykinesia, that's slow movements, rigidity, and tremor, define MSA. Well, it turns out bradykinesia, rigidity, and tremor are also the motor symptoms in Parkinson's disease and Lewy body dementia. Cognition, such as memory and hallucinations, these things can also happen in Parkinson's disease and Lewy body dementia. The timing of the symptoms and the type of symptoms are what differentiate these different disorders clinically. Pathologically, there are very different things under the brain. It turns out these little Lewy bodies, so what you're looking at is a slice of brain tissue from someone who very generously donated their brain after they died. And those little pink blobs here that the Lewy body is pointing to, those should not be there. Those are abnormal clumping of protein, and you see a magnified picture right below it. This is a Lewy body. This is the same pathology that we see in Parkinson's disease and Lewy body dementia. It's the exact same pathology. Multiple system atrophy, these have little abnormalities. So that bright black thing, that is called a GCI, or a glial cytoplasmic inclusion. This is the pathology in MSA that is seen. And so again, you see a high power picture below it. So both of these are different pathologies under the microscope. Now they're both made up of the same protein, alpha-synuclein. It's just that the Lewy bodies are in the nerve cells, whereas the GCIs are in a different type of cell called a glial cell. So the pathologist can tell the difference, but it's impossible to tell the difference in a patient right now doing something like an MRI scan. So we define these based on the clinical picture. So a diagnosis of Parkinson's disease with cognitive impairment or dementia is used when the memory problems develop within the context of typical Parkinson's disease. A diagnosis of Lewy body dementia is appropriate when the diagnosis of dementia or severe cognitive problems either precedes or happens at the same time within 1 year of the development of the motor symptoms of Parkinsonism. The diagnosis of MSA is appropriate when there's a primary autonomic dysfunction along with either Parkinsonism or ataxia, again, with or without memory problems. This is even more complicated by the fact that both Parkinson's and Lewy body dementia can also have some autonomic dysfunction. So these are themes throughout all three of these diseases, but the severity and the timing are what we use to define whether it's called Parkinson's disease, Lewy body dementia, or MSA. And I have to say, as a specialist in this field, this is a really, really hard thing to do, and we get it wrong sometimes. And that's why autopsy studies are so, so critical, so we can learn when we get it wrong and how we can do it better. All right, so that is my last slide. We have time for questions. I just want to make a quick plug. We're trying to gather more information from patients and family members who have gone through their experience with MSA and learning more about their experience and their symptoms because there just aren't a lot of research studies out there in this disorder. If you have time, we have a quick 20-minute online survey that just asks about someone's experience with MSA and symptoms. We'd love for you to take that. You can be either the patient or a family member or caregiver of a patient. We ask you to identify which you are at the beginning of the survey. Please consider doing that. And I'm going to finish up by just showing you that this is our Stanford Movement Disorders group. We have a very, very large group of physicians here, all of whom help to take, everyone on that top group there are all of our adult neurologists who do take care of patients with MSA. And we are going to finish up our time here with some questions. So Candy, I'm going to pass it on over to you now.
Okay, thank you so much, Dr. Poston. That was great. And we do have a lot of good questions here for you as well. So our first one is, as we advance our slides here. Having a little technical difficulty here. I apologize.
If when will the diagnostic criteria change?
Okay, one question that we do have here while we're trying to get our questions rolling is, when will the diagnostic criteria for determining if a patient has MSA, when do you think that'll happen?
So new consensus statement on MSA. So it's in the works right now, and I think it's hopefully will be happening in the next year or so. But it's a very long process where they're pretty much gathering all the information they possibly can of every single published autopsy case that's come through, and really looking at which of the diagnostic criteria are helpful and which are perhaps not helpful. So I hope in the next couple of years, but I don't know for sure. Good question.
Yeah. The first question here on the slide, I think you've already addressed, so we'll go on to the second one. Why aren't MDs able to determine if someone has MSA or LBD, which is Lewy body dementia?
Yeah, it's the problem is that even though on the pathology, as I mentioned, the Lewy bodies look very, very different from those glial cytoplasmic inclusions. Right now, there's no brain scan, there's no blood test, there's no cerebral spinal fluids test that can definitively distinguish these two things. This is a very big area of research. It's what I spend most of my time doing, is trying to develop these kinds of brain scans that will do a better job. But right now, it's only based on the clinical symptoms and the timing of the symptoms. And so if someone isn't sure when the timing of something happened, it can make it very difficult.
Are there any specific assessments or screenings that you recommend for evaluating and monitoring an MSA patient's cognitive status?
It's a great question. And so there's sort of two elements of this. There is the screening. So what would a primary care doctor or a neurologist do kind of on a day-to-day or a visit-to-visit basis? There are a couple of screening tests that are very good. There's one that's called the Montreal Cognitive Assessment that actually has questions in all of those different domains that I mentioned, particularly executive function, attention, working memory, that is very good for screening. Now, the problem is that it's fast and it's only 30 questions. So it's not quite detailed enough to get into the details. And so there is a secondary, more comprehensive, what we call neuropsychological battery. That takes 1 to 2 hours, sometimes 3 hours of cognitive testing. It can be very long, a little bit tiresome, requires a specialized PhD in clinical neuropsychology to do it, but that can give a more broad question. So your physician can do a screening test like the MOCA in clinic, but for more extensive testing, you need to be referred to a clinical neuropsychologist who can do formal cognitive testing.
Okay, so the next question here is, how are executive functions affected in MSA? I know you talked about that a little bit, but maybe we want to circle back.
Yeah, so this can come across oftentimes as difficulty with multitasking. So today's world requires so much multitasking. And you see people riding their bike and checking their phone at the same time. No one's ever doing one thing at a time. And really multitasking is one of the things that requires a very high level of executive function. And that's oftentimes one of the things that patients first describe to me that they struggle with is that when they have too many things going on at once, they just can't prioritize, they can't organize them. Figuring out the right things to do in the right order to optimize getting everything done. It can be as simple as trying to come up with your to-do list for the day and prioritizing it. So this is probably the ways in a sort of day-to-day real life that executive function manifests itself.
Okay, and you did talk about this as well, but not specifically. How common are hallucinations in MSA? Can there be hallucinations without Lewy body dementia?
Yeah, so there can be hallucinations without Lewy body dementia. I think that's really what those recent studies have convinced us of, that that you can have hallucinations in the context of pure MSA pathology. That was not something that was really known 10 years ago, but with recent studies that has been documented for sure. And I have seen it in my clinic as well. It's not that common, but it absolutely happens.
Okay. How does dementia in MSA differ from Lewy body dementia, Parkinson's disease dementia?
It can be pretty darn similar. It really, the dementia itself, again, this executive dysfunction, that's also commonly the most common kind of problems that people with Lewy body dementia have, or Parkinson's disease dementia, which is why the neuropsychological testing itself, while it helps the patient and the physician understand the type of cognitive problem, it does not help in differentiating the underlying pathology. So they can be identical.
Okay, so how does the cognitive impairment in MSA differ from what is seen in progressive supranuclear palsy, or PSP?
Yeah, so this one can be a little bit different. So patients with PSP, while they can have a lot of executive dysfunction as well, they oftentimes can have more judgment problems. So a common thing that can be seen is patients with PSP have very poor balance and are very prone to falls, and yet they, they'll just spontaneously jump up from the chair and try to walk, even though they know that their balance is so bad. Now, this can also very much happen in patients with PD and MSA. It's just more common to have that sort of poor judgment in PSP than in MSA and PD. But I will say I do see it in MSA and PD as well.
Okay. This one, somebody in our local support group brought this issue up. My husband is now very susceptible to TV ads and asked me to order products we do not need. Is this executive function impairment?
So it is a bit of executive function impairment, but it's also showing a bit of impulsivity. So that idea that sort of the bright, shiny toy that's in front of you that you can't walk away from and you really want. While it can be a part of the underlying disorder, it also can be made worse with certain medications. And dopamine agonists are the traditional ones that can increase this impulsivity. And just so you know what the dopamine agonists are, these are ropinirole, which is also known as Requip, Premapaxol, which is also known as Mirapex, and then the reticotine patch, which is also known as the Nupro patch. These are the three most common dopamine agonists that are used here in the United States. There are some others used internationally, so I apologize to my international audience for people that I don't know all of the non-USA brand names. But these dopamine agonists can really worsen this impulsivity and this desire to buy things.
Okay. This is something I experienced. My husband is now slow to respond, slow to make decisions, and has on and off periods. Is this dementia?
So it depends on the degree to which those on-off periods and decisions are impacting, again, the ability to do the day-to-day activities of daily living. So the slow to make decisions, this is that processing speed where the patient can get to the right answer or they can figure it out. It just takes a long time to get there. And again, processing speed was really one of those that kept coming up in those studies as very specifically affected in MSA. So that's slow to respond. The on-off periods could, again, be on-off from blood pressure fluctuations. They could be on-off from medication fluctuations. And in some patients, it's just really hard to identify the trigger of those on-off periods. So not necessarily dementia, but could be within the spectrum of what we see in someone who's experiencing dementia as part of their MSA.
Okay, yeah, it's very hard to figure out, I'm sure. Yeah. Could MSA-related cognitive impairment be mistaken for vascular-related mild cognitive impairment?
The only study that we have that addresses that was the one that I showed. And if you look out of those 33 participants, I believe there were 4 or 5 that had vascular disease found at autopsy. And so, yes, in those, 4 or 5 out of 33, there was at least a vascular component. To be honest, if someone has both MSA and a vascular component, I don't think we can tease out how much of the cognitive problem was from the MSA versus how much was from the vascular component. But in those patients, the pathologist thought there was enough vascular disease that it could be contributing. So it is possible, but not that common.
Okay. How can you tell the difference between orthostatic hypotension and cognitive impairment? That's a great question.
It's such a good question. Yeah. It's such a good question. And I think, again, the most common place that we see this is when blood pressure drops and then a patient is not able to respond as quickly. Again, that processing speed really slows down. They can't answer the right questions. Really, the only way to really tell the difference is to test blood pressure when this is happening. But then we can also sometimes do formal autonomic testing. So again, here at Stanford and many other places, we have an autonomic lab where they do this test called the tilt table test, where someone's laying flat and then they slowly tilt them up to standing and they watch as the blood pressure drops. I've sent a couple patients to that testing where I've had them do cognitive testing laying flat when I know their blood pressure was normal. And then after they did the tilt up, they repeated the same cognitive testing to see if they did more poorly. And that way to actually, in a formal testing way, see if this person was really having cognitive changes directly associated with the blood pressure. Sometimes it ended up to be, looked like that was the cause. In other cases, it didn't look like it was the cause.
Okay, great. In our local support group, people with MSA are taking Alzheimer's medications such as Aricept and Exelon. Does this mean they have dementia or Lewy body dementia, perhaps?
Yep. Oh, sorry. Can you hear me?
Yes.
Okay, sorry. I hit a button on the microphone.
Oh.
Okay.
Oh, you're there.
Yeah, good. Yeah, that's a great question. So as far as medications to treat cognition, Alzheimer's disease is the only neurodegenerative disorder where we have medications that have been FDA approved to symptomatically treat the cognition. Aricept, which is also known as donepezil, Exelon, which is rivastigmine, and then there's another one that's a different type of medication called memantine, which is also known as Namenda. Those are the most common ones. Now, the problem is that's all we have. And so they've been FDA approved for Alzheimer's, but we use them in things like Parkinson's disease, Lewy body dementia, and MSA. Basically, if you have a neurodegenerative disorder and there's cognition that's affected, these medications are the only ones we have to offer right now. So we borrow them from Alzheimer's and use them in our patients. Now, the best data supports the use is behind Aricept and Exelon in patients with Parkinson's disease and Lewy body dementia. I have not yet seen a research study that's looked at these in patients with MSA and cognition, but I can tell you from my own experience that I have used them and they do help a little bit. Not great, but they can definitely help. So it doesn't mean that you have dementia or Lewy body dementia. It just means that that doctor thinks that these medications might help with cognition and memory.
Okay. And so how is the care of a person with MSA different from someone with dementia, or different from someone with other neurological diseases such as PSP or CBD?
Yeah, so, I'd say even the care of any two patients with MSA is completely different. If there's anything we have learned with these in-depth longitudinal studies of people with neurodegenerative diseases, is that every single patient is completely different from other ones. If you've seen one patient with MSA, you've seen one patient with MSA. And so the problem is that every patient, the care is specifically tailored to what symptoms they experience. So for instance, if someone has MSA and no urinary symptoms, then that's not something that the caregiver has to worry about. Whereas another patient with MSA who has severe urinary incontinence, that could have a big impact on day-to-day life. So it really depends on the individual symptomatology, and that's across PSP, CBD, MSA, Parkinson's disease, Lewy body dementia. It is 100% symptom by symptom.
Okay. So do you have patients that have been diagnosed with MSA that don't have the urinary issues?
There's usually at least urinary frequency, but there are some patients who don't have the complete incontinence. It's just more urinary frequency, particularly in the first 5 years. It can be very quite variable. Yeah.
Okay.
Yeah.
If someone with MSA has cognitive issues, is his or her progress or the survival time any different?
We don't know, honestly. The one study showed that, again, the chance of having cognitive problems was higher in the patients who lived greater than 8 years after their diagnosis. But then once they have cognitive problems, if their prognosis or survival time was shortened, we don't know in MSA. We do know in Parkinson's disease that is true, that once someone has the diagnosis of Parkinson's disease with dementia, their prognosis and survival time is shorter than someone who has Parkinson's disease without dementia, but we just don't know if that is true in MSA or not.
Okay. So how can you did touch on this, but you might want to add to it. How can medications affect cognition?
Yeah, I'm gonna combine this one with the next question, because that's the biggest issue, is the opiates. So anything that treats pain dulls the neurons in the brain. That's how pain medications work, because they in a good way, to help people who are in a lot of pain, they slow down the processing and they kind of block a lot of the nerves in the brain. But they do so in a non-specific way that affects a lot of nerve cells in the brain. And so anything that treats pain other than Tylenol and ibuprofen or naproxen, the over-the-counter medications, once you get into prescription pain medications, opiates and non-opiates alike, these can all slow cognition, they can cause confusion, and they can absolutely cause or worsen hallucinations in somebody with MSA. And so what we try to do is we start off, if someone is having pain, starting off with the over-the-counter medications, if tolerated for other medical reasons, Tylenol, ibuprofen, naproxen. But again, some people can't take those for other reasons. And then if you have to go to something prescription, you really need to talk one-on-one with your primary care doctor and neurologist about the safest thing to try, because, and I'd say start at the lowest dose possible, because all of them can, in fact, worsen cognition and hallucinations.
Right. A little bit goes a long way. We certainly experienced that. Yeah. So can cognitive problems be prevented in MSA?
Unfortunately, right now, we don't really understand what causes the cognitive problems. So we don't have a way of preventing them from occurring. So it's something that I think we have a huge need for within the field of MSA, but we're not quite there yet.
Okay. How do you think caregivers should respond to somebody with MSA and a patient with MSA and their cognitive problems?
Such a good question. It's hard to, because especially if it's in the context of this executive dysfunction, patients can get really frustrated. And what family members recognize, often without knowing that they recognize it, is that patients do improve with certain amount of cueing. Like, if someone's having trouble figuring out what to do next, or whether there's an appointment, to say, "Oh, remember, honey, why don't you check the calendar?" Unfortunately, what we as medical professionals call cueing, spouses call nagging.
Right.
And so that's the problem, is that it comes across oftentimes as bothering or nagging. And so I think there are two things that I often try two sort of ways I try to address this. One of them is knowing what the problem is. If someone really is having a hard time recognizing it, getting that formal neuropsych testing, getting some data that you can discuss it around can be helpful, rather than saying, oh, honey, don't you remember the time last week when you had a hard time doing this? That makes it really personal, and people get defensive when it's personal. Whereas if you talk about data, like, do you remember that test where you had to connect the dots and you had trouble with it? That's a little less personal because it's more of a test, and you can have it in the context of the doctor. Make the doctor the bad guy. It's okay. We can live with that. Sometimes make them say it to the patient, so it doesn't create that interpersonal dynamic that can be very difficult with family members.
Right. And then we're going to combine these next two. Can people with MSA also have Alzheimer's disease or Lewy body dementia?
Yeah. So yes, they can, but as that one autopsy study showed, it's rare. So Alzheimer's was in about 4 of those patients. No one in that specific study had both Lewy bodies and an autopsy diagnosis of MSA, but I know in the literature there are at least a couple of case reports of that happening, but that's really not that common. It's pretty rare for someone to have both Lewy bodies and MSA.
Okay. When do we determine, moving on to some advanced, about employment, when do we determine when the patient is unable to work because decisions are cloudy or cognition is impaired?
Really depends on the job and the level of flexibility that the employer has. There are definitely some patients who have the kind of long-term relationship with their employer where they can move into a different role that maybe doesn't require as much decision-making and can be a little bit more a little bit easier, but this is really going to depend on performance, the relationship between the employer and the employee, and whether or not roles can be changed to accommodate. But unfortunately, I think most of the time, once we get into, again, executive functioning, because it is really critical to decision making, it's very hard to be employed and not be making good decisions about, even small things.
Right. And if you could speak to this, in your experience, once a patient is nonverbal and unable to move on his or her own accord, is this considered a disability automatically?
I'll say that in filling out disability paperwork, particularly anybody, with the types of symptoms that we see across the spectrum of MSA, even before they get to the point where they can't speak or move, they usually do qualify for disability. It is the government that decides if you qualify or not, but based on the paperwork, I've never had someone denied with MSA.
Okay, great. That was our experience too. Yeah. And then when do you get involved with determining if a patient is able to drive or not?
Yeah, so this varies by state. So in the state of California, if someone has dementia, they're required by law for the physician to report them to the DMV that they are evaluated for whether or not they can drive. That is not true in other states. This is a state-by-state issue. There are certain places, so occupational therapists can oftentimes do an assessment before we get to that point to sort of test someone, and they have, a lot of times they'll have a driving simulator I know here in the Bay Area. There's one of these within the Kaiser system. We have one of them here at Stanford where they can do, again, long before someone has a diagnosis of dementia, if the patient or the family or the physician's worried, they can do an occupational therapy assessment to see what the concerns might be. As I mentioned, those visual spatial symptoms like clipping of corners, those can come into factor with driving, and you just want to be aware of them.
No, for sure.
Yeah.
So once again, I think I want to thank you, Kathleen, for. We do have a few more questions. Okay, so here's our link for our survey once again. So we would really appreciate it. Everyone that's been participating today, if you could copy this link and fill out the survey for us, we would really appreciate it. And we do have a couple more questions that came in. Is there any connection of HPH and MSA?
NPH.
NPH, I'm sorry.
NPH, yeah.
Can they occur together?
So normal pressure hydrocephalus, NPH, is a condition where the fluid in the brain that's normally there starts to build up because it's either not draining correctly or not recycling correctly, or more fluid is being produced than should. And this can cause the spaces in the brain to enlarge and to press against certain parts of the brain. The typical triad of symptoms associated with this are gait difficulties, urinary dysfunction, and cognitive dysfunction. So those sound pretty similar to what I just described with MSA, right? So they can be confusing. Clinically, the type of gait dysfunction is very different. The type of urinary symptoms are different, and the type of cognition is a little bit different between them. So clinically, we can usually differentiate these. But the way to really diagnose NPH is with a brain MRI scan. You should be able to see, again, these large ventricles and certain other specific features on the MRI scans. This is one of the reasons why you get an MRI. So the MRI can't say for sure you have MSA, but it can be used to identify patients who are at risk for NPH, but they are different disorders completely.
Okay, and here's another one that came in that's a good question. What is fatigue's role in cognition?
It's a really good question. So obviously when you're fatigued and you have no energy, you know, your brain's just not working quite well enough. And I think processing speed in particular is really affected by fatigue. Again, fatigue, very involved in blood pressure as well. When the blood pressure is low, there's a higher propensity toward fatigue. But what we know in both MSA and, again, those Lewy body disorders, Parkinson's disease and Lewy body dementia, there's a lot of fatigue that's just fundamental to the disorder itself. So there's a lot of interplay, and it's hard to tease apart what's the cognitive, what's the blood pressure, what's the fatigue. I will say that fatigue oftentimes gets at least a little bit of improvement with napping or resting, whereas maybe not as much with blood pressure fluctuations or dementia.
And this kind of speaks to this next question I have, is what is sleep's role in cognition?
Well, I'll tell you, you get a bad night's sleep, you're not thinking clearly the next day. That's what I learned from my residency. But it's really true, right? I mean, it's you get a bad night's sleep and just nothing quite, it's harder to do everything cognitively. Again, processing speed, very, very heavily affected, executive dysfunction. And so one of the ways to, again, we can't completely fix dementia, but making sure a patient is sleeping as well as they can. So if they have obstructive sleep apnea, that's properly treated. Making sure they're napping during the day if they need one. Making sure their blood pressure is properly being monitored. All of these things, even though they're not causing the cognitive impairment or dementia, they sure can worsen it. Medications, same thing. So optimizing all the things that we do have more control over can improve the overall cognitive state of a patient. So we can optimize cognition by making sure we have everything else as tuned up as possible.
Okay, and we'll wrap it up with this last question. What's the importance of brain donation to MSA research?
It's absolutely critical. So those studies that I showed today, if we didn't have the autopsy proof that these patients had MSA, we'd go another 20 years with doctors saying, oh, dementia is not part of this disorder. It must be a misdiagnosis. It must be something else. And until you have the autopsy confirmation, you can't do this kind of research. In fact, 30 years ago, people thought MSA was 3 totally different disorders that looked a little bit differently from each other. And it wasn't until a pathologist recognized that all 3 of these different disorders had the same underlying pathology did the term MSA and the fact that these are the same thing finally come about. And so much of our research has been heavily, heavily dependent on patients who so generously were willing to give the gift of brain donation. It's the only way to move forward at this point.
Well, thank you, Kathleen. This is just fabulous information. I'm sure everybody that tuned in today really appreciates your time. I know we do. So once again, everyone that's participating today, please fill out the survey. Let us know how we can improve for our next webinar for you.
And thank you very much to the Brain Support Network and to you, Candy, for hosting and doing all of the legwork behind this. I really appreciate it. Thank you, everyone, for participating.
Okay, and also watch your email for the link that will for the summary of today's webinar and the link to YouTube. So that'll be coming in your email shortly. Okay, thank you, everybody.
Thank you.
And good afternoon.